to fill out, correct? So let's take a look and see which forms you're going to have the patient fill out. Now, I know times are changing. You know, the typical way in which patients fill out forms nowadays is for the patient to come into your office and you hand them a clipboard with a nice health history form and all your questionnaires and health history intake forms, and they fill them out. But I know times are changing now. Some of the docs that I work with, they have patients go to their website, go to the doctor's website, and fill out the forms online. Some offices have patients go to the website and print out the forms, fill them out, and bring them in already completed. Some offices have created a patient portal where patients can create a username and password, and then they can fill out the forms that way. Plus, they have access to their records. They can look up and see what you've recommended. They could access you and send you emails. So there's a lot of different ways in which patient information could be obtained nowadays. However, if you would just like your patients to come in the old-fashioned way and fill out forms, that's okay. It's okay to do that. So regular health history forms, if the patient's been involved in some sort of workers' comp injury or personal injury, auto accident, you should have separate forms for those situations. Notice of privacy practices is a very important item to add to your list of forms that the patient should fill out and be aware of. The notice of privacy practices is part of the updated HIPAA rules and regulations that occurred just a couple of months ago. So notice of privacy practices is important. Sometimes docs will say, Marty, I'm a cash practice. I don't really have staff. I just have a few patients. I'm a cash practice. Do I still have to give a notice of privacy practices? Am I HIPAA, am I a HIPAA, do I have to be HIPAA compliant? Yes. You need to make good faith efforts to protect your patient's private health information, whether they have insurance or not, whether you have staff or not. Authorization to release medical information, authorization of payments, an auto deduct form. Maybe you want to set it up where you just automatically do an ACH auto deduct out of the patient's checking account or off of their credit card. Terms of acceptance form. Some malpractice insurance companies require that. How about just a general office policy form? Outcome measurement forms, like the Oswestry, Roland Morris. Those are great forms for the patient to fill out on the initial visit. Any other forms specific to your practice? Maybe you're a pediatric practice, so you want to have those types of forms. There's a lot of different forms. Make a copy of the patient's insurance card, front and back. So let's talk a little bit about an office policy form. This is one form that I recommend my clients use. It's just basically the ground rules. Your office is your baby, right? You make the rules. It's your house. You decide where the chairs go, what color carpet you pick, right? It's your place, so you set the rules. Just basic rules. When you go on an airplane, you should put on a seatbelt, right? But they still go through the rules with you. So you should still go through the rules with every patient, even though some of these things are basic. Signing in. Patient signs in, patient arrives, you want them to sign in. You want them to tell you if they've had any new injuries. If you do healthcare classes, tell them it's important. Tell them it's strongly suggested they attend. Payment of bills. Well, that could be a whole separate policy. Rescheduling appointments. Progress evaluation. See, I've learned a lot of my successes from my failures. I remember doing a re-examination on a patient, and she comes in a few weeks later and says, Dr. Cutler, what's this charge? How come you charge my insurance company an extra of X number of dollars for this re-exam? I said, Mrs. Jones, you don't remember a couple of weeks ago I had you come in, I did a re-evaluation? She says, yeah, I remember that, but you never told me there was going to be a charge for that. See, just by some little communication lapse, I learned a lesson. I had to eat that balance. I didn't communicate properly, so you learn. So now I tell patients, it's on my policy. We do progress evaluations. They'll be performed periodically to determine your rate of progress and your future course of treatment. There's a fee for all progress evaluations. A special time will be set up. Upsets, we're here to serve you. Please speak with the staff or doctor about anything that could be upsetting you. We see your comments as helping us help you and others. I, patient name, have read, understand, and agree to the above office policy. Think this is a good thing to have? So this is just one sample. You want to have good quality forms. I repeat, good quality forms. Your intake form. Your intake form can help substantiate some of the codes you're billing. Your intake forms can save you a lot of time. Nowadays, the biggest complaint I get from my clients is there's just not enough time in the day. I'm working with one doc right now. She sees 100 visits a day. She's spending about a minute on each soap note. That's 100 minutes a day just on soap notes. Well, I looked at her soap notes. They're not that good. So she now has to spend about 2 minutes per soap note. That's 200 minutes per day just on soap notes. That's over 3 hours a day just on soap notes. Time is an issue. So how do doctors, what's one way for the doctor to be able to save time? Get staff and patients to do more of the paperwork within normal limits. Your staff cannot come up with a diagnosis. Your staff can help do the history. Their patients can help fill out some of the forms, like the outcome assessment forms, to help determine medical necessity. Start thinking about that. Time is the key factor nowadays. I can tell you what to do. I can tell you what not to do. I can't make the day longer than 24 hours. Next is treatment plan. Check out every insurance company that you bill. Look at their policies and procedures. They will say a treatment plan is required. It's no longer optional. You have to create a treatment plan for every single patient you see. Even your cash patients, yes, even your cash patients. It doesn't have to be as detailed. It doesn't have to be as prolonged. Why? Because you don't have to prove medical necessity to anyone. If it's a cash patient, you only have to prove medical necessity to the patient. You don't have to prove it to a third party. So those treatment plans and those care plans don't have to be as extensive. But when it comes to billing an insurance company or for risk management purposes, you need to create a treatment plan. It's no longer optional. And a treatment plan is not, oh, I recommend the patient come in 3 times a week for 12 weeks and then 2 times a week for 8 weeks and then 1 time a week for 6 weeks. That's not a treatment plan. That's part of a treatment plan, but that's not a treatment plan. So let's take a look at the next slide. Creating a chiropractic care plan begins with your patient's first visit to your office. You should do a history, exam, come up with a diagnosis, set goals for the patient, list the services you're going to render, and the schedule of care. To me, that's the abbreviated version of what constitutes a care plan, a treatment plan, plan for care. I don't care what you call it. You have to put together a game plan for the patient's care. Now, if you're going to see the patient, if you're a practice that's pain management only, I work with quite a few chiropractors where they're just into pain management. They see patients 3, 4, 5, 6 times, and that's it. Well, you don't have to get too extensive with your care plan. It's very limited. Most chiropractors don't do that. Most chiropractors see patients more than 6 times. So if you're going to see a patient more than 6, 8, 10 times, you should be creating a very thorough treatment plan. So it starts with a history. There are 4 levels. There's a problem-focused history, expanded problem-focused, detailed history, and a comprehensive. So problem-focused would equate to CPT code 99201. Expanded is 202. Detailed, as you see on your screen, is 203. Comprehensive, 204, 205. So if you're billing insurance companies and you're billing for 99203, that means you need to do a detailed history. Most of the doctors that come on board working with me, they do not know how to explain, or a staff member does not know how to explain what a detailed history is. Do any of you? Can you give me the bullet points? Think about it. Do you know what constitutes a detailed history? We're not talking about Well, I think I do a detailed history. Well, they taught me in chiropractic college how to do a detailed history. My friends, showed me how to do detailed history. Forget about all of that. We're talking about a third-party payer. If you're billing 99203, the insurance company has guidelines. The E&M guidelines. Allstate, State Farm, Geico, Blue Cross Blue Shield, Aetna, Cigna, they all follow these E&M guidelines. So let me share with you what these guidelines say. The guidelines say that you have to have at least one chief complaint for, I'm talking about 99203. It's the most commonly billed new patient code. One chief complaint, 4 HPIs, 2 to 9 systems need to be reviewed, and one item from the PFSH. So let's go through each one. A chief complaint. That's pretty straightforward. It's a concise statement describing the symptom, the condition, the diagnosis, or other factors. That's the reason for the encounter. The HPI, or in chiropractic college, you were probably taught it as the OPQRST. So what's that? The onset. What makes it worse? What makes it better? The quality of the pain. Is it sharp, dull, burning? Is it radiating? What's the pain scale? How long has the patient had it? Anything changed since the onset? Has it ever happened before? Is it intermittent, constant? Does exercise make it worse? Does it feel worse at night? Does it feel worse while standing? What conditions does the problem prevent the patient from doing? Any associated signs and symptoms like numbness, tingling, swelling? Has the patient ever seen a chiropractor in the past? Those are some of the basic questions you should ask new patients. Staff can ask those questions. Next, ROS, 2 to 9. Okay, there's a lot of systems in the body. ROS stands for Review of Systems. HPI stands for History of Present Illness. So we have the ROS. Many systems, there are 14 systems in the body. You have to cover 2 to 9. Could be as simple as, Mrs. Jones, any problems with your heart, lungs, bowel, bladder? Patient says no. You just covered 4 systems. One item from the PFSH, that stands for Past History, Family History, Social History. Just one of those. That's pretty easy, right? So please make sure you're doing these things. If you're billing 99204, big jump with the system review. More and more insurance companies are scrutinizing the history and E&M coding in general. So make sure you're meeting the requirements. Next is the exam. Okay, next portion, 202 to 992. So now the exam. When you're doing exam, let's just go through the basics. Okay, so for 99203, you need 12 exam findings. 99202, 6 to 11. 99201, as little as 1, up to 5 findings. 99204, you have to perform all elements identified by a bullet. Document every element in each box with a shaded border and at least one element in each box with an unshaded border. That's part of the E&M guidelines. So let's just go through the exam a little bit. Basics. Let's go through the basics. How are you going to start accumulating your 12 exam findings if you're billing 9920 them or link them properly? We're denying the services based on the fact that your diagnosis codes are inconsistent with the procedures you're providing. Your diagnosis codes, you want to make sure they're accurate. For example, if you're going to do a soft tissue treatment, for example, myofascial release on a shoulder, a good diagnosis would be shoulder stiffness. You want to code to the highest degree of specificity. I don't recommend you use probable diagnosis codes, suspected, or working diagnosis codes. In my opinion, you're better off waiting a few visits to submit a claim that has a definitive diagnosis than submitting an incorrect diagnosis code. ICD-10 is coming starting next year. Just a little heads up, starting in January, we have a 12-part series on ICD-10. Every month it's going to be a different topic for the entire year leading up to the October 1st start date. So if you're interested in that, please go to targetcoding.com and sign up for our free ICD-10 webinars. They're going to be about 20 to 30 minutes, just a quick update on what's going on and give out a few pearls. We're going to be recording them for our members. So again, ICD-10 is starting next year. We're going to be doing free webinars. It's a 12-part series. Part 1 is on January 16th. January 16th is the first one. The first one, what I'm doing is I'm just cutting to the chase. I'm just going to give out the most common ICD-10 codes. So be prepared. ICD-10 is coming October 1st, 2014. I already looked it up. It's a Wednesday. Wednesday, October 1st, 2014 is when ICD-10 starts. Okay, let's get back to today's webinar. Goals. That's the next step, goals. You should start with your patient intake form. You have to create clinical goals for patients. It's not an option anymore. Start with goals on the intake form. Gather baseline numbers in the consultation. Ask the patient questions about activities of daily living. Also gather baseline numbers in the exam. Goals should be feasible, include a time frame. They should get updated as the patient improves. Range of motion is an excellent way to measure patient function. Outcome measurement forms, as I mentioned earlier, like the neck disability. I think any patient comes in with a neck problem, you should have them fill out a neck disability. Lower back, I like 2 forms, Oswestry and Roland Morris. Any upper extremity problems, I like the DASH form, D-A-S-H. Any lower extremity problems, I like the lower extremity functional scale form. Again, get the patients to fill these out, and you could monitor progress by having the patient create their own fate in your practice. Next, services and rationale. So what services are you going to render? Therapeutic exercises, neuromuscular reeducation, therapeutic activities. Make sure you have the clinical rationale. Make sure you could prove that this patient needs these services. For example, I have a lot of clients, when they come on board, they're not billing properly. I'll give you an example. A lot of docs, they come on board, they're billing 97110. That's therapeutic exercises. What's the purpose of therapeutic exercises? To increase range of motion, flexibility, to strengthen muscles, correct? Yes. So what should the patient have a lack of when they come in? Range of motion, muscle strength, right? So this is what I see oftentimes when clients first come on board. They're billing 97110 because they know they can get paid easily, but you look at the clinical documentation, the patient's range of motion is normal, and there's no muscle function deficiencies, but the doctor's billing it because it's getting paid. That's a problem. So revisit that. Any service you're providing, understand what your intended outcome is supposed to be and see if the patient has a deficiency. Another example, neuromuscular reeducation, 97112. That's typically used for improving balance, coordination, kinesthetic sense. So what should the patient have a lack of when they come in? Balance, coordination. That helps justify the code. So here are some examples as far as what services you're going to render. ICE, heat, EMS, traction, manual therapy, massage therapy, of course, chiropractic adjustments, DME, x-rays, strapping, kinesiotaping, orthotics, functional evaluations, trigger point therapy. Well, that's maybe if you're an MD-DC practice. Lab work, weight loss programs, nutritional consultations, re-exams. A lot of choices. Schedule of care, basics, 3 times a week for 4 weeks, twice a week for 4 weeks, and then you're going to reevaluate. Okay, we're up to step 3. Moving right along, step 3, SOAP notes. Let's go through some of the basics. SOAP, SOAP notes. Never alter your records. Malpractice attorneys can hire expert document examiners to analyze chart notes. There's no faster way to damage your credibility in court. If you get caught altering, changing your records, you're better off not having records, no records at all, than get caught changing them. Careful. You have to make a change? Just enter today's date. Make the change. It's okay. Sometimes you forget that you did electrical muscle stim on a patient. So next day, go in, make the change, but enter today's date. Don't backdate anything. Don't make conditions seem worse. Record your patient's conditions accurately. Don't make them sound sicker or healthier. Some providers have admitted to falsifying records just to stay in network. Document missed appointments. Document if the patient isn't attending your healthcare classes. Document if the patient is not following your home care instructions. Very important as far as risk management. I don't know how many of you have ever been involved in a malpractice case. Fortunately, I haven't. Was never involved in malpractice, but I have some clients. They're presently involved in malpractice cases. It's very upsetting. It's very stressful. Any information, you could have a very happy, friendly patient one day, all of a sudden becomes your enemy because they want to sue you. It's very upsetting. It's very frustrating. So what do you now need to do? You need to start building up ammunition. If you told the patient to come in 3 times a week and they were only coming in once a week, that might be useful information for your attorney to use to help fight this case. So you should write all that stuff down. If you didn't write it down, it didn't happen. You've probably heard this before. In today's healthcare environment, it has more relevance than ever. Your documentation must accurately reflect your clinical thought processes. Uncommon abbreviations. Abbreviations are a wonderful tool. It can help save time if you're still handwriting your notes, which is okay. You could still handwrite your notes if you'd like. If you make up your own abbreviations, you're going to have to send out a key or a legend. Or just try your best to use standard abbreviations. Document normal and abnormal findings. On a particular busy day, you may be tempted to record only abnormal findings. Careful. Although abnormal findings are important to determine the diagnosis, negative or normal findings are equally important because they can help rule out conditions. For example, negative straight leg raise, negative Bechterew, negative Valsalva, normal reflexes, normal sensation, normal motor strength. Well, that's how you rule out disc injury. Home care instructions, very important. More and more insurance companies and medical directors of insurance companies want providers, not only chiropractors, physical therapists too, occupational therapists, to give patient things to do at home. Why? It helps speed the healing process. So be specific when giving patients instructions for home care. First, start giving patients home care instructions. That's number one. Number two, make sure they're specific. Telling the patient to use ice? Well, tell them how much to use, how long to use it, how to apply it. Exercise instructions include details. I had these tear pads. I'd check off all the different exercises I wanted the patient to do. I signed it, the patient signed it, dated, made a copy. We kept the original, gave a copy to the patient. There's the proof. I'm making a good faith effort to get this patient better as fast as possible. That's part of medical necessity, is doing things and giving things to the patient to get them better as fast as possible and in the most economical manner. That's part of the definition of medical necessity, is giving the patients things to do, providing services to get them better, fast, in the most economical manner. If you don't do that, what does that mean? You're trying to prolong the situation. You're trying to bill for services that are not necessary. See how that could be a problem? Follow-up care. Always document when a patient should return for follow-up. If a patient is told to call the office when care is needed, be sure to indicate that in the records. When no date for follow-up care is noted in your records, an attorney could allege this is evidence of abandonment. I know that sounds crazy. Just sharing these stories with you because I've seen it happen. Hopefully it'll never happen to any one of you. If the patient is being discharged, document that. So as far as SOAP notes go, here's what I consider the perfect SOAP note. This is a SOAP note that has all the items needed to pass an audit. SOAP. It talks about how the changes, about any changes that have occurred since the last visit. So it has some comments about an ADL. The assessment. See, the assessment could be pretty simple most of the time. Patient is improving. Overall, patient is improving as expected. Patient is about the same. Yeah, you could use that on every visit. But every third or fourth visit, my recommendation is that your assessment provide a little mini progress report. Mini. I mean mini, like 2 sentences. So this is a sample SOAP note. Objective, I like the basics, tenderness, spasm, areas of subluxation. The assessment, lumbar tenderness and spasm has subsided approximately 20%. The patient was able to bend a little easier since the last visit. Neck and upper back are the same. At present time, patient's response to treatment has been favorable. Under the P, just what you did. I adjusted C1, C5, C6, T2, T9, and the right SI joint. I did therapeutic exercises for 15 minutes. I did manual therapy. Every time-based code, you must write down the amount of time you spend doing those services and the anatomic site. Next, linking and pointing, that's step 4. So box 21 of the 1500 form, by the way, we're getting a new form. I'll share with you in a couple of minutes what that looks like. So you want to make sure your procedure codes are pointing to the diagnosis codes in box 21. This is called pointing. See on the right side, 98940 is pointing to positions 1 and 2 in box 21. The myofascial is just pointing to number 3. That's lumbar disc degeneration, 722.52. And the extremity adjustment, 98943, that's pointing to number 4. That's shoulder pain. That's specific. You want to document. You want to code to the highest degree of specificity. You want to be able to tell as much of a story on these 1500 forms as possible. So why? So you can get paid fast. This is the new 1500 form. You can start using it January 1st. There's a phase-in period for the first 3 months of the year. You could use the new one or the old form. Come April 1st, you have to start using the new form. This is a little close-up of the top 13 boxes of the form. You'll see there's a QR code in the top left corner, a couple other small changes in the top portion of the form. The bottom portion of the form, box 21, that's the big change. You'll see box 21, you see it's 12 positions labeled A through L. That's the big change of the new form. You can go to nucc.org for all the latest updates on the new form. It's going to be form 0212 in the bottom right corner. So now I just wanted to show you the differences between the old form and the new form. The existing form has 4 spaces in box 21 labeled 1 through 4. Box 21 of the new form has 12 positions labeled A through L. There's a strategy to billing these out. When you attend my ICD-10 webinars coming up next year, I'm going to be going over what are the best ICD-10 codes to put in box 21. This was created for ICD-10. ICD-10 has so many more diagnosis codes, they had to expand box 21 to make it more specific. And now here's another example of pointing to avoid bundling. We have the 98941, myofascial, hot pack, stim, and therapeutic exercises, all to different parts of the body. So patient comes in, you have your initial diagnoses, 12 visits later, you update your diagnosis codes. As the patient gets better, you update them. So you don't want to use the same diagnosis codes over and over and over again. It'll increase the chances of your claims getting denied. Insurance company saying, oh, the care is not medically necessary. You have to prove medical necessity. I have a form in one of my coding guidebooks that helps you pick the best diagnosis codes to maximize reimbursement. You want to get paid properly. If you have sciatica and lumbar sprain on a patient and you have to submit one code, don't submit the sprain, submit sciatica. Sciatica gets paid for more visits. It's a higher value code. You're going to code to the highest degree of specificity. Use diagnosis codes that pay the most money. Why not? I'm not saying pick diagnosis codes just because they pay a lot. For example, sciatica. That's going to pay more than lumbar spasm. Don't use sciatica if the patient doesn't have it, but if the patient has it, figure out your strategy. So if you're interested in the guidebook, contact Natasha at 1-800-270-7044 or go to the website. You'll see our guidebook on the best diagnosis codes to maximize reimbursement. All right, we're up to step 5, cash plans and financial policies. Have you ever tried to figure out how much it costs you to give a patient an adjustment? I'll show you how to do it. Let's say your overhead's $10,000 a month, and you see 100 visits a week or 400 visits a month. It costs you $25 a visit. That's from Ray Foxworth. He gave me this information. Ray Foxworth is the owner of Chiro Health USA. So, have you ever thought about doing this? The lower the number, the better. I have one client. I ran these numbers. It came out to $35. Very high overhead. He's not seeing that many patients. It's coming out to $35 a visit. I asked him, Doc, how much do you charge your cash patients? He said $30. I said, that's not good. It's costing you $35 and your cash patients are paying $30. You're losing $5 each visit. Now, I understand some patients you're going to give free care. I did that. It's done sparingly. Patient has a severe financial situation, reduce the fee, give them free care. It's okay. You're allowed to. Have them sign a financial hardship form. That's okay, but it should be done very, very sparingly. Your cash patient should be paying at least what it costs you to deliver an adjustment. Here's another question. Is one fee across the board really possible? Is it possible to have one fee for every man, woman, and child that comes into your practice? I don't think so, because you have your normal fees, your standard fees. You have managed care fees, right? Managed care fees. Let's say you're participating with Blue Cross Blue Shield through ASH in some states. In other states like Illinois, it's through OrthoNet. Aetna in some states deals with ASH. United Healthcare and Optum Health have a relationship. So you're in network with these plans. Your normal fee could be $50. Well, they're only paying you $30. What's your then what's your fee? Is it $50 or $30? So again, your normal fee is $30. You're in network with a plan. They're going to pay you $30. Your normal fee is $50. You have to write off $20. Next. Mandated fees, Medicare. Your normal fee is $50. Medicare only pays you $25. You have to write off $25. Then we have workers' comp. Personal injury. Everybody loves personal injury. You're going to get paid your normal fees there. You have time of service fees, hardship fees, DMPO fees. That stands for Discount Medical Plan Organization fees. You could be part of some or all of these. That doesn't mean you have a dual fee schedule. So, is it possible to have one fee? Probably not. So my recommendation is, when it comes to fees, is you should have a policy. Your policy should sound something like this. I have one fee for my practice. And the only time I provide a discount is when I'm required to, because of a contractual network agreement or because of a patient's financial hardship. So you want to give the impression. Your policy should be, I have one fee schedule. You don't want to be accused of a dual fee schedule, charging more to insurance than your cash. Careful with that. That could be a problem. More and more doctors are getting in trouble. Years ago, I never saw that as an issue. Now it seems to be more of an issue than ever before. So be careful. Be smart. You're running a business. You want to protect your business. You want to be a smart businessman. Yes, you're a chiropractor. Yes, you want to help patients. Yes, you want to help people get well where they cannot through other sources. So you are the answer to their health. Wonderful profession. It's amazing, but it's also a business. You're not a non-for-profit center. You should be running your business just like you're running a Dunkin' Donuts, an ice cream store, or you're running a major corporation. It's a business. You want to be profitable. Just because you're a healthcare provider doesn't mean you should be giving away free services. So avoid dual fee schedules by giving this impression. I have one fee for my practice, and the only time I provide a discount is when I'm required to because of a contractual network agreement or a mandated fee or because of a patient's financial hardship. All your patients should be aware of your normal fees. Some providers give discounts only to their cash patients, and they don't let them know. So you give discounts to your cash patients, but you don't let them know your normal fees. That can come back to bite you in the butt. It could cause sticker shock. Hopefully you understand what I'm referring to. Let me explain it, because this is important. Your normal fee is $50. A cash patient comes in and you say, Mrs. Jones, you're cash, right? Oh, yeah, you don't have insurance? It's $20. Oh, okay, thanks, Doc, great. You don't tell them your normal fee is $50. You just say, you know what, you don't have insurance, it's $20. Now the patient's in a car accident, they get insurance, and now you're charging $50, and the patient's upset. What's going on here? I was coming in paying you $20. Now because I have insurance, or I was in a car accident or hurt on the job, now you're charging my insurance company $50, $100, $150? Why are you doing that? So you could avoid that by having good communication, letting patients know your normal fees. And then there's time of service fees. You can give a little bit of a discount, 10%, 15%. That's okay, because you're passing on the administrative savings to the patient. There's prepay plans. Be careful with prepay plans. This is where a patient pays for multiple visits in advance. Offering prepay plans to insured patients could violate your agreement. In-network agreements could prohibit collecting deductibles and copays in advance. Never collect deductibles and coinsurance upfront from Medicare patients. Prepay plans are great. Patients come in, they don't seem to complain as much when they prepay. They show up for their appointments. They're well-educated patients on chiropractic. They refer others. So I like prepays, but you have to be careful. You may need to put the money in an escrow account. Don't rely on what your friends tell you. Don't reward patients. Like, Mrs. Jones, I'm recommending 30 visits. If you get all 30 visits, I'll give you a free iPad. Don't do that. And then you have discount medical plan organizations. You see it on your screen, DMPOs. My recommendation, as far as which one, I like Chiro Health USA. There's others. I've checked them out. None of them compare to Chiro Health USA. They're number one as far as I'm concerned, and they can help you with discounting your fees legally, preventing dual fee schedules. If you become a member of Chiro Health USA, you can charge insurance $300 a visit, and you could charge your Chiro Health USA patients $30 a visit. What? Yes. You could charge insurance $300 and your Chiro Health USA $30. That's a huge discount. That's a 90% discount. You can do that legally through Chiro Health USA? Yes, because you become part of a nationwide network. Can't do that on your own. Works with cash patients, underinsured. It could work with Medicare patients and high deductibles. You could start with Chiro Health USA and then connect it to an auto debit. That's the best way to do it. So you should have a financial consultation with every patient. Put it in writing. It gets patients to understand your billing and collections procedures. Remember, patients probably don't understand that collecting money from insurance companies is not easy. Let them know. A policy helps educate patients about acute care versus chronic care versus wellness care. It gets them to understand they are responsible for a portion of the bill. It enhances communication with patients, prevents doctor-patient upsets. So just a few closing comments. We have something called our SWAN program or our Smart Choice program. Our Smart Choice program will help you SWAN, sleep well at night. See, we're all about prevention. We want to prevent problems. Most of the doctors we work with, most of my clients, are not being audited. They're not being investigated. They're not under any suspicion of fraud. 80% of the doctors I work with, they say, Marty, I just want to prevent problems. I want you to take a look at my codes, make sure I'm billing properly, make sure I'm maximizing reimbursement. That's what this program is about. It's not a membership. It's a short-term evaluation and recommendations, report of findings, and you're on your own. So this will show you how to prevent audits, how to strategically bill Blue Cross Blue Shield, Aetna, Cigna, United Healthcare, and PI. You should be collecting cash for many products and services. Some doctors are so afraid of audits, they're underbilling. That's a shame. You need to know how to code to the highest level of specificity. You need to know how to prevent dual fee schedules, when not to use modifiers 52 and 59, how to build time codes properly. So this program focuses on medical necessity, cash plans, coding, billing documentation, a forms review, compliance, and maximizing reimbursement. Let us know if you're interested. We also have memberships. They start at $99, go all the way up to $5.99. All memberships include unlimited questions and answers, plus you can attend all our seminars and webinars. We have a seminar coming up this week. If you act quick, you could become a member and come to this week's seminar for free and get CE credits. It's included. I have clients I haven't seen in years. All of a sudden, they're showing up at the seminar because they want CE credits. They're not coming for me. They're coming for the CE credits. That's okay. I don't mind. It'll be great to see them, but that's okay. You get free CE credits when you're a member of Target Coding. So we have a whole bunch of upcoming seminars on ICD-10, webinars, and live seminars. We have general record keeping, chiropractic record keeping, and compliance seminars coming up. So call 1-800-270-7044 or visit targetcoding.com for more information. Get on our e-newsletter list. If you're not getting our monthly e-newsletter, we give out a little coding tip of the month. Oftentimes we give out a free form you can download right out of the newsletter. Get on our e-newsletter list. It's one of the best in the industry. So, just a couple of closing comments. You must check with all the carriers you bill prior to submitting claims based on the information provided in this presentation to ensure that it is compliant. Target Coding does not guarantee that the information provided in this presentation will guarantee payment from any insurance carrier or patient. Target Coding is not responsible for any insurance carrier or managed care organization laws, rules, guidelines that may change following this presentation. It's important you do your best to stay on top of these changes by attending seminars, webinars, and joining your national and state professional associations. So I want to thank everybody for attending this webinar. Again, our contact information is info@targetcoding.com, website targetcoding.com, and our telephone number is 1-800-270-7044. We have tons of training manuals. I think I'm up to 10 or 12 training manuals that I've written specifically for chiropractors. Check out our product line. Again, we offer memberships and Smart Choice programs, seminars, webinars, guidebooks. Okay, let's go to questions and answers now.